This video lecture is going to talk about trauma to the central nervous system. It'll cover a lot of terms you and I covered in the trauma lecture earlier this semester, but today we want to focus on it in the perspective or the focus of the nervous system itself. When we take a look at trauma to the central nervous system, primarily the brain, but also spinal cord, we can look at blunt force trauma, vascular trauma, or developmental trauma. With blunt force trauma, there's some type of physical impact that's causing actual direct damage to nervous tissue itself. And it commonly can be considered either closed injury or an open injury. So closed injury is usually an impact. If you're in a car accident, if you fall, if you're tackled, some outside trauma that hits your skeletal system and then causes damage internally. Nervous tissue actually has some good self-protective mechanisms. When nervous tissue is suffering trauma, very commonly it shuts off that part of the nervous system because it doesn't want to use something that's weak. And so it temporarily sets it up into almost like a mini coma while the body tries to reset. And so a traumatic brain injury or a concussion is where you've had blunt force trauma enough to cause the brain to say, okay, this part of the nervous system is not working right now. I don't want to keep trying to run an engine without oil. So I'm just going to turn it off for the moment and let it reboot. We used to think, or well, we used to say that a true concussion required loss of consciousness. We now realize that's not correct. Instead, we say loss of contact. That means almost like our absence seizure, where the person just kind of loses it for a little bit. The difference is that absence seizure is usually a very passive event. A concussion, again, has some type of closed impact. And the person is, has their bell rung, is disoriented, and then kind of reestablishes. And a lot of times they very quickly appear perfectly normal, but there's always the risk that there was some trauma in there that will remain forever. So you've always got to be careful about every concussion that you suffer because it doesn't always heal 100%. So be mindful of that. Spinal cord compression, that happens in a lot of falls and a lot of impacts. And the danger here is that swelling of the soft tissues in around the spinal cord may put pressure on the blood flow to the spinal cord or may put direct pressure on the cord itself and may turn off signaling within the spinal cord. And so when I was in EMT in Colorado, we were called to the university one time. The cheerleader squad was practicing doing a big pyramid, but they're on protective mats. One of them fell right on her back, and when we got there, checked her out, she was nervous because she couldn't feel anything or move anything from the waist down. We stabilized her, checked her out, got her to the hospital, and she regained full control of everything. It was just a momentary swelling that just temporarily shut everything off. But obviously, we had to stabilize everything to make sure there wasn't like broken bones that might slice tissue. We don't want to make anything worse. So spinal cord compression is something that can happen very quickly, and you have to be very, very careful with the treatment of it. Locked-in syndrome is the idea of, we found this in a number of long-term comatose patients where trauma has caused them to disconnect to any of the outward abilities. So motor abilities, they can't speak, they can't move, but we find that a lot of these individuals are fully awake and aware. And so they can hear what you're saying. And so, this is where you've got to be very careful if you're ever dealing with coma patients. You can't just flippantly make a lot of comments because they could actually be listening to what you're saying. Be mindful of what you say. We've even found some patients with locked-in syndrome still have eye muscle movement control. And so when you talk to them, they can move their eyes, and we're developing techniques to be able to follow the eyes and use that for communication. Open injury is a penetrating wound. So that'd be like a gunshot or an impalement, stabbing. And so there, generally, the issue is either loss of blood flow or direct impact if you get shot or stabbed right into the brain itself. And again, the trauma is going to depend on, or the result is going to depend on exactly where the trauma occurs. Secondary impact, always be mindful for the brain, because remember that the brain is a soft structure inside a hard bubble. And we talked about this back in trauma lecture. Remember that your brain is floating in a pool of CSF, and if you get rear-ended in a car and your forehead hits the dash, when your skull hits, if your brain hits the front and you have damage to that part of the brain that correlates to the impact site, that'd be considered a coup injury. But if your brain bounces off the inside of the skull and damages the back, you could have vision issues. That would be a contra coup. So just because your patient has a goose egg here, do an MRI, do a CT, look for any internal bleeding or swelling. You don't want to rule out trauma somewhere else in the body because of coup versus contra coup impact. I had a football player give a lecture one time about concussions, TBIs, and stated I'd rather get tackled than fall on a gym floor, and told a great story about that. And I want you to think about that and explain what is the rationale for that statement. What does that mean? Think about coup and contra coup, and I want you to be able to explain how all that fits together. Vascular trauma is something that stops oxygenated blood from reaching brain structures, whether it's an aneurysm or it's an embolism, something that we don't have good oxygenated blood flow to a structure. If it's a temporary lack of blood flow, that's ischemia. And specifically, when we talk about in the central nervous system, we'll refer to a cerebral vascular accident or a stroke. And that would be the result of that ischemia to that part of the brain. A TIA is a transient ischemic attack. That means a reversible stroke. When your patient has suffered a stroke, we will give them clot busters, we'll give them fluids. We want to keep oxygenated blood flowing through. We want to reestablish oxygenation as quickly as possible so that we can turn that CVA into a TIA, because a TIA has a much better chance of recovery. Now ischemia is lack of blood flow, so that's usually our obstruction, our embolism, for example. Hemorrhage is bleeding. And so if we've burst open an aneurysm or if we've had a blood vessel tear apart, we're going to bleed. Bleeding in an enclosed space like the skull could lead to either a hematoma or a contusion. A hematoma is a pocket of blood. That's where blood is flowing into spaces between organs, and it's going to start creating a space-filling lesion. The brain's very soft and spongy. Blood in that area is going to start pushing on that brain, squeezing it down like a sponge, preventing good oxygenation of the tissues. Want to reverse that as quick as possible. Contusion is if the blood actually soaks into the tissue of the brain itself. This is very bad because your body's going to then form blood clots that are going to crush nervous pathways, and that can cause permanent damage. And your body's effort to try and clot bust and macrophages chewing up that clot could damage neural pathways. So again, this is why we give them lots of clot busters. We do everything we can to let the blood soak in and flush out so that we don't have those blood clots and the fibrinolysis of breaking up the clots, which will damage surrounding tissues. With the hematoma, we talk about that pocket of blood. Cranial hematomas can be epidural or subdural, outside of the meninges or within the meninges. And this is very important to understand because that circle of Willis is that set of blood vessels on the underside of the brain that feeds everything. Those are the ones that are feeding all of that cerebrospinal fluid. That's where you're worried about things like aneurysms and embolism. But if that blood runs all the way through this space inside here and then goes back out to that outside area with the subarachnoid space, if you have a epidural hematoma, that's where you have arteries outside the meninges. If these get ruptured because of some type of brain injury, that's going to push blood into that space outside the meninge. It's not going to cause a contusion. It's going to cause a hematoma, but that's going to squeeze down. Now, being arterial means high pressure, fast acting. A subdural hematoma is where we have the veins on the inside of the meninges break, and they're going to bleed. And again, they're going to cause a space-filling lesion, squeeze it down, but being venous, they're much lower pressure, they're much slower acting. Here's the trick question for you. Which is worse? And it's a trick question because bear in mind that an epidural is going to bleed fast, got to treat it fast, but it's also going to present quickly. Subdural is going to bleed slowly. It's not going to show up right away, but it's got longer to deal with it. So, give you an example. Your buddy is helping you to string up lights around the house for the holidays. They're up on a ladder. They fall off the ladder, they hit the lawn, and their head hits really hard, ring their bell. If they have an epidural, they're going to get up and they're going to very quickly start acting sluggish. They're going to show you signs and symptoms of something bad enough that you call 911, get an ambulance. You have a quicker chance of getting someone to treat them. That's an epidural, that's fast. Very little time to react, but you tend to see an issue right away. Subdural, they get up and they're going to feel fine, maybe a little headache, a little disoriented, and they're going to want to go lay down for a while. That's stupid because it's going to slowly bleed. They're going to take a nap and never wake up. And so that's where, like I said, bear in mind the epidural is quick to identify, but you have very little time to treat it. The subdural, more time to treat it, but it's easier to miss because you don't have signs and symptoms show up right away. Any fall, get treated. That's the end result. That's the take-home message. Here's an example of a subdural hematoma. The blood slowly filled into the area. The person probably had exactly what I talked about, that they had some impact and it slowly just went in and it just squeezed it down and they just simply fell asleep and never woke up. Oof. The FAST assessment is focused assessment with sonography for trauma. Make sure you know what FAST stands for. This is a rapid ultrasound assessment we use to look for signs of internal bleeding. This is one of the best ways we can tell if we suspect your patient has had a stroke. We use this to do ultrasound of the pericardial space, the abdominal space, and we can see major bleeding occurring within the body and quickly analyze to see if there's having an internal vascular trauma. It's not a perfect system. If they have bleeding in other areas, it's not going to show up on the FAST assessment. And if you have pregnant or obese patients, a little bit of blood loss somewhere between all of that tissue in the torso may not be as readily apparent. So it's bear in mind their limitations, but it's actually a very accurate assessment that has helped us to early diagnose stroke and treat it much more quickly. So it's been a very useful tool for us to use. Developmental trauma is blunt trauma to the central nervous system, brain and spinal cord, at a very early age. Cerebral palsy occurs if that trauma happens during the fetal period, that's our third trimester, or shortly after birth. And so if mom was hit with a steering wheel in a car when she was in her third trimester of pregnancy, or the baby falls shortly after birth, this can damage the brain. And the largest frontal lobe has a lot of your motor and cognitive skills. This is the most vulnerable spot that can cause a little bit of shearing and damage some of those pathways. Shaken baby syndrome, this occurs later into the neonatal or toddler age, most commonly around age 3, but it can happen anywhere between age 1 and age 5. As the name implies, that shaken baby, remember again, weak neck muscles, big bony cage, and a fragile brain inside. If you're shaken back and forth, that's going to wind up damaging pathways inside. That could cause pathway damage. And if it's a mild form, it may damage a little bit of the brainstem area that controls digestive functions, respiratory functions. And so they may have diarrhea, constipation, vomiting. They may have eating disorder. The sluggish and grouchy is poor oxygenation to the brain because of poor breathing control. If they've had severe shaken baby syndrome, then this can damage more of the cerebral lobe, and this can result in the seizure and heart irregularities. And so nasty, nasty stuff. Be able to identify this, to notice this. All right, that's the super quick overview of trauma to the nervous system. Gave you a bunch of terms. That's going to be your biggest key for this little lecture component is know the terms like contusion, concussion, ischemia, hematoma. Know the terms, know how they apply. Good luck.